So liver cancer is a complex disease. Unlike a lot of malignancies we treat, all of these patients come with two comorbidities. One is their underlying liver disease, and the other is their malignancy. The association between liver cancer and cirrhosis is very tight. 90% of patients do have underlying liver disease, and therefore the outcomes for patients with liver cancer will be dictated by their tumor burden as well as their liver function. And so staging systems that are designed to predict outcomes for patients with liver cancer really need to take into account these two factors. So the Barcelona staging system has gravitated to being one of the most commonly used globally, and it breaks patients down from very early stage liver cancer at stage 0 to A, B, C, and D, D being patients who are very advanced and probably ready for hospice care. And the patients with Barcelona D are usually in that condition because they have very decompensated liver disease. They have Child-Pugh C. The Child-Pugh score is a way that we commonly assess liver function, taking into account the bilirubin, the albumin, INR, whether or not they have ascites or encephalopathy. And patients with Child-Pugh C disease are expected to die from their cirrhosis probably sooner than from their liver cancer. Whereas patients with earlier stage liver cancer will have better compensated liver function as well as smaller tumors. Then we break patients into potentially curable, would be the patient with 0 or A disease. Those are patients who could be resected or undergo radiofrequency ablation for well-compensated liver function and small tumors. And then the bulk of patients we see present with Barcelona B or C. Barcelona B being considered intermediate, which are often multifocal tumors in the liver. These patients may have some decompensation in their liver function, but they do not have tumor growing into their blood vessels or tumor outside of the liver, and they also have a good performance status. And then the Barcelona C are those patients who are advanced. These are patients who are appropriate candidates for systemic treatment, assuming that their liver function is adequate. That is to say that they're not the decompensated patients. When we assess someone with liver cancer, really the assessment I have is this patient going to die of cancer or from cirrhosis? And then if it's going to be the cancer component, what is the best treatment for that patient given their stage, based on their tumor burden, performance status, and other characteristics? So because liver cancer is complex and there's that interplay between cirrhosis and cancer, really it takes a multidisciplinary team to manage these patients at least the best, giving them the best opportunity for good outcomes. The reason that is you involve the oncologist, the hepatologist. Certainly liver transplant plays a very important role in managing these patients. It is a curative modality. There's few malignancies that we do a transplant for. We would never transplant a lung for lung cancer, but liver cancer does tend to stay in the liver for a while before it spreads outside the liver or before it develops advanced characteristics like growing into the vasculature. So therefore, liver surgery needs to be involved, as well as interventional radiology. Interventional radiology plays a huge role in managing these patients. Patients who have smaller tumors potentially can be cured with radiofrequency ablation if they can't be operated on. Or patients who have multifocal disease in the liver certainly benefit from catheter-based approaches such as chemoembolization, and increasingly Y90 is being used for those intermediate patients as well. So when we see a patient, it's important to get input from everybody. Is this patient be curable with surgery? Are they within transplant criteria? Transplant criteria are constantly changing. So it really behooves us to have a patient, I think, assessed at a transplant program with a new diagnosis. And then are they a good candidate for local regional treatment, or are these patients who unfortunately might just present with advanced disease and need systemic treatment? Many patients we have, I would say majority, present with intermediate liver cancer. So they have liver-confined disease, multifocal tumors. They still might be transplant candidates based on the criteria or if they can be downstage. And these patients will often get interventional radiology-based treatment, chemoembolization or Y90. But those are not curative either, right? And so we know that patients who have these procedures will eventually become resistant to them or stage migrate and become advanced. So they'll either develop tumor outside the liver or they'll develop tumor growth into the vasculature, so that we call this macrovascular invasion. And that doesn't mean just the extrahepatic portal vein, but inside the liver, the vasculature in the liver. Or they'll have a chemoembolization, and on their next imaging, they'll all of a sudden have many new tumors developing, or you can't completely kill the tumor that you're targeting. And those are all times to transition to systemic treatment, right? Local regional treatment, usually patients get a treatment, they're followed, imaged at a regular interval. Often we do what's called TACE on demand. So if they have a new tumor, they get another treatment. But at some point, you start damaging the liver function, right? Every time you do a TACE, you do take away some liver function. And at some point, we can't keep up with the tumor growth, or like I said, it develops characteristics of advanced disease, and that's a time to start thinking about systemic treatment. And the oncologist or the hepatologist who's ever managing that medical component, giving systemic treatment, needs to be involved in the conversation, because it's not readily known that all the new treatments we have available for liver cancer that have been proven to extend survival. And if a patient continues to get local regional treatments to the point that their liver function is compromised, they can't benefit from those treatments. So I think we're looking at solidifying that interaction between local regional treaters, interventional radiologists, and medical oncologists and hepatologists to help define when we stop TACE and start medical treatment.